It's really an immense kind of pleasure to participate in this sort of invitation of Emmy Lomos and to engage with all of you. I'm sorry I can't actually see all your faces, so there's no possibility of me seeing you. But I'm just very glad to be able to hear you later on in your questions and to engage with the other participants. So as I was saying, thank you, Emmy. I've got the first slide up. Thank you very much. So as I was saying earlier, I will actually in this presentation be drawing on collective research. So it's not just my research, but it's research of everyone who is interested in these issues within our Centre for Cultures of Reproduction, Technologies and Health, which is based at the University of Sussex. But we have members both nationally across the UK and also internationally who are active and who help us sort of put together these kinds of findings. So the two main bits of work I'll be referring to are the submissions of research evidence that we presented to the Women and Equalities Committee inquiry into the unequal impact of coronavirus, and the other piece that I'll be drawing on will be the submission of research evidence on inquiry into the access to contraception, which was submitted to the All-Party Parliamentary Group on Sexual and Reproductive Health in the UK on the 22nd of June. And it's important you have this, these two links here, because this is something, this is where you'd get also all the references to some of the things that I'll be mentioning. So if we could have the next slide. So thank you. So getting back then to the focus of today's meeting, which is on gender mainstreaming and social inclusivity in COVID-19 responses. What I'm going to do is I have 15 minutes. So I'm going to just draw out some kind of key issues that have struck me and have come out from our joint collective work as we submitted it for this, in terms of research, this research evidence. So what I think one of the kind of key things that is useful to keep in, to really keep at the forefront is that in this context of gender mainstreaming and social inclusivity, in the context of the COVID-19 pandemic, it is important really to keep human rights and a justice approach right at the forefront. And this is because often in pandemics, it is easy to overlook some of these sort of key principles of human rights. That, human rights means that we have to have, everyone has to have equal access to health services. These are services that have to be holistic. They must cover, not just health issues, but also social and cultural issues. They must, everyone should be able to participate. It should be inclusive. That's this whole thing about social inclusivity. And whatever is provided is, people need to be accountable in terms of governance issues. They need to be accountable and transparent in terms of their guidelines. And of course, above all else, everyone needs, access to acceptable and high quality services. So it's really important to keep, human rights principles in the forefront, especially when we're thinking about gender and mainstreaming and social inclusivity issues. And beyond human rights, I think we also need to keep in mind reproductive justice, paradigms in mind. And this is because reproductive justice is an important framework, particularly in contexts where people might not know of or be fearful of accessing the law and accessing those human rights standards through the law. So it is really important that we have this kind of combined approach of thinking about human rights, but also sort of a justice approach. The other kind of key issue that has emerged in whatever material that we've looked at in the center is that there are huge gender and intersectional data gaps. So there is a gender data gap, and the thing is that these gaps are there in any case, but they become really highlighted in the pandemic, and particularly in pandemic responses. So, for example, the paucity of research, the lack of research on women's differential experiences of disease and suffering, which is there before, is now seen to be much more in the forefront. This is because we've seen that, perhaps women and men, and they might have very different the prevalence of COVID-19 would be very different in them, and for that we do need to have that framework to investigate these kinds of issues. Secondly, the gender data gaps lead to they're very important because they a lot of the design of the tools, the kinds of equipment that's used for example, for healthcare providers, this is based on this kind of research of the differential gender needs. So, for example, we've seen where healthcare providers who are women, most of the visors and the protective apparel has been designed for men, and this doesn't fit women, and particularly in context of COVID-19, we see that this really increases the risk for healthcare providers if they are not well protected. Sorry, can we go to the can we go further down or to the next slide? Thank you. Then, of course, the another key issue that has emerged is really about the timing, and when do institutions and when do organizations respond to the pandemic? In what ways do they respond? And what we found is that it's very important to have an early engagement in with what's happening, and also sort of translating that engagement and research into guidelines early on, and then for these guidelines to be continuously kind of updated and monitored. And in that sense, we found that the guidelines provided by the Royal College of Gynecologists and the Royal College of Midwives have been really quite exemplary in the UK. They right from from early briefings and excellent guidelines from say the 9th of April, and consistently from then, weekly, monthly, we have had good briefings in terms of what both to healthcare providers, what they should be doing, but also information being set out for women and men as well. So, for example, early research that was collected and disseminated through the RCOG, on which their guidelines were based, was really things like in pregnancy, for example, the idea that pregnant women may not be, the difference between pregnant and non-pregnant women in terms of risk isn't very significant, isn't there. But there is an increase in risk for women later on in their pregnancies, in the third third trimester. Similarly, the idea about research that was tentative but has been highlighted is that there might be some forms of vertical transmission taking place. Pregnant women and children may be at risk of that. So either in the antenatal period, the transmission of the virus from mothers to the fetus, or in the postnatal period between the mother and the child, there may be some risk of that. That was already kind of highlighted in these guidelines. Similarly, the idea that actually the risk of women who are pregnant increases when there are other comorbidities along with the pregnancy, if you are suffering from other kinds of ailments, and such as they mentioned, diabetes, etc., and any other kind of ailments. And one of the important findings has also been about how these comorbidities seem to be more prevalent in women from ethnic minorities. So these research findings have been both highlighted and acted upon early on by the Royal College of Gynecologists and midwives, and they were available for people to connect up with. Sorry, could we have the next slide then? The other sort of finding that we have had is that in terms of service access and the issues to do with how people access services, access sexual and reproductive health services, and of course this has been dominated by the provision of services online. But then also thinking about how and with the Royal College of Gynecologists and of midwives, but also the Faculty for Sexual Reproductive Health and Medicine in the UK have been very reflective on this issue and think about both the opportunities, of course, with online prevention, but also their limits. So for example, in terms of antenatal care and birth, the issue about how the move to online may have exacerbated the delay in accessing care, and to what extent also does it mitigate the fears and anxieties of women and men who can't access antenatal care. So does even the fact that you can't access care face to face, does that prevent you from accessing adequate information? But it's also the fact that health services are overwhelmed, and so women might actually experience delays, health system delays in access to these kind of emergency or comprehensive obstetric services. Another really important factor in terms of these fears and anxieties are that there is and there has this restricted access, particularly becomes even more so for people in self-isolation during the COVID lockdown process. And these issues combined can increase depression, both in the postpartum context, but also in the perinatal context. And so it is really important to have psychosocial support, and often policy and program responses are kind of linked to emergency and critical events and not necessarily sort of focused on these kind of mental health responses. So that is really important. Sorry, can we go a bit lower in the slide, Emmy Lomo? Thank you. Could we just see the rest of the slide, Emmy Lomo, the one that's, sorry, no. I seem to have lost the screen now. But I see, yes, the other point is really about some of the options that have been given to women delivering in health services, in institutions and in hospitals. And we see, for example, so I'll come to this slide in a minute, but I'm just finishing the other slide, which is about how in hospital settings women have been enabled to have a birth partner with them. And this is really important because birth partners are important for emotional support, they're important for communication. And the RCOG guidelines say that an asymptomatic birth partner, single asymptomatic birth partner is to be allowed with women as they give birth. Sorry, we move to the next slide then. So along with these service issues, I just talked about the ones relating to birth, but there are also really important service issues relating to the access to contraception and the access to abortion. These are sort of major issues in ensuring reproductive and particularly sexual health. So they are very important. With contraception, we found that there's been a speedy switch to phone consultations and transmission of online prescription in the UK. And this is for most of the contraceptives except for long-acting reversible contraceptives. Again, what the experience has been is that it's very difficult for those who are self-isolating to have access, because often while you get the online prescription, you have to go to the pharmacies themselves to access this. So you might have the prescription, you might have the consultation, but then the actual access might be difficult for those who are self-isolating. Similarly, not all services, not all sort of primary healthcare trusts, etc., have been able to provide online services. So there's been a rapid commissioning also of online service organizations, which has taken place. There were tender frameworks set out. So a lot of work has gone into that. With a key issue with these the online provision has been that often, and this is again, you need things in place before such pandemics break out, but there's been really a lack of sensitive tools to collect information from groups who already have difficulties in accessing contraceptives. So when you have online services, it's very essential, and not much work has gone into that yet to ensure that it is addressing the needs of people from different British, from different Black and minority ethnic communities. Because one of the things have been found recently in the research is that there is a lower level of uptake of and particularly repeat prescriptions among BME service users. Very briefly, and most of these points are elaborated in the research submission and in the documents I mentioned earlier on at the start of the talk. So I will just thank you. Yes. So I will just the references are here. There's and the different people who've contributed to this are all mentioned in their research. So I'm not going into that in detail. So apart from contraception and access to contraception services, we also access to abortion services has been very important. And sorry, can we go back to that slide, Emmy Lomo? Thank you. So it's, yes, thank you. So if it's the next slide, please, and the next one, and the next one. Thank you. So if we look at the abortion services, we found that actually something rather dramatic and I would suggest very good has happened with the move to online services, and that for the first time we find that online services have been organized for complete early medical abortion with counseling, and this is also been kind of, I mean, in a sense, it's part of the guidelines. And this, for the first time, there is an acknowledgement that women can actually self-manage their own abortions at home. This is supported by, medical and treatment packages sent through the post. So again, it's very important that we've had the, maintenance of postal services during the pandemic. It is also shown that that the certification of having abortions, that huge barrier has also been addressed, because now this can take place through online means, and this has been accepted. However, there is as yet the support and for the access of sort of ethnic minorities in terms of abortion as well as contraception is yet to be sort of developed. And I think part of this issue is also to do with the fact that these communities have not had support for access, special support in terms of their access for abortion and contraception, because amongst some of the research that we did in the UK, we found that particularly access to abortion information and contraception was very poor, and really needed special sort of development in ethnic minority communities. We work specifically with South Asian, Pakistani, Indian, and Bangladeshi communities, and found this to be the case. And then I guess, you know, the final point that I really want to put across is that we've been talking a lot about, you know, face-to-face. We've been talking a lot about the face-to-face versus online, and online as being this kind of, you know, great sort of panacea for helping us in this pandemic. But and it has to a large extent with abortion, we find this specifically so. But I think one of the things we forget is that it's not only about face-to-face and online, it's also about issues to do with touch and physical contact. And we have lost that in the pandemic. We have lost that kind of contact, which is so important for healing and for emotional well-being. So I'm going to stop at that, and I look forward to your comments. Thank you very much.